Let's hear about the diagnostic challenges faced by a patient with bipolar disorder.
Hi, my name is Catherine and I'm 24 years old and I see myself as an average college student. Last year I was diagnosed with bipolar disorder after several years of dealing with depression.
What are some of the other ways that we look to sort of unmask in the clinical history things that might point us in the direction of bipolar disorder?
Episodes of depression that begin in a clear-cut way relatively early in life, before age 25, let's say.
Early age of onset.
Are more likely to be within the bipolar spectrum. And depressions that are associated with prominent psychomotor retardation as well as reverse vegetative features, overeating, oversleeping, are more likely to occur within the bipolar spectrum.
I love your phrase of probing questions, and I think we all have our key things that we look for in bipolar disorder. I certainly look for insomnia and irritability. I say to my residents, I look for bipolar disease with two eyes, the eye of insomnia and the eye of irritability.
I think every person treating depressed people should have a easy to use, reliable measure of depressive symptoms that they incorporate in their practice. And we'd expect, if we were being treated for diabetes or hypertension, we would expect our doctor to use a metric that reliably estimated the disease.
Because no matter how often we use screening tools, PHQ-9, mood disorder questionnaire, they're screening tools, they're not diagnostic tools.
I'm fascinated by this discussion of approved agents. I'm also fascinated by the conspicuous absence of the most commonly prescribed psychiatric medication for folks with bipolar disease, and that's the class of antidepressants.
These are truly complementary effects. There are some patients who have such a level of deep dysphoric arousal that they can't think clearly enough or comfortably enough to make psychotherapy work. That patient benefits from being on the medication, whether it's a second-generation antipsychotic, a mood stabilizer, or a combined regimen. That dampens that arousal. The patient can then begin to learn and engage in psychotherapy.
I really appreciate my doctors that I have now because previously I had a psychiatrist who was very distant and didn't ask me any questions, and I just felt that she was there to give me my medications. I felt like I was part of a drug deal. I didn't feel any personal connection. I didn't know anything about her, and she didn't know anything about me, so I felt that she didn't care for my welfare. And
I often tell my trainees, patients don't believe in doctors because of medicine. They believe in medicine because of doctors.
I think helping them understand this is an illness that they're going to manage, not cure, and that you want them to use all the tools and not to underestimate the use of the supportive counseling or psychotherapy approaches.